Hi everyone, and welcome to the 5th week of the 2017 installment of the INSAR Summer Institute. We are still working on a few technical issues, but we're going to go ahead and get started. I'm Christina Cottle. I'm the co-chair of the INSAR Student Training Committee and a postdoctoral fellow at the University of Utah. I would like to welcome you all to this week's session of the INSAR Summer Institute featuring Dr. Jennifer Singh. This session is number 5 of the 6-week online series presented by the International Society for Autism Research. We'd like to thank the INSAR Board of Directors for their support in this event and the INSAR Student Training Committee for the dedication to organizing this session and this actual whole series as well. For those of you who have not been following the series, I'm going to give a brief overview of kind of our mission with the Summer Institute. Specifically for the 2017 installment of the Summer Institute, we focus on topics on culture and diversity. The concept for this year's Summer Institute was largely conceptualized based on participant feedback. We really appreciate and encourage you to share any feedback you might have regarding the Summer Institute or any Student Training Committee events. There will be an opportunity to submit feedback following today's session as well as at the end of the summer. The Summer Institute was designed to provide a forum for the presentation and discussion of autism-related research topics that is accessible for people new to the field. We originally wanted this to be an opportunity for career researchers, specifically graduate students and postdocs, to learn about unfamiliar areas of autism research. However, we are excited to invite anyone interested in autism research to listen and participate. We hope that the Summer Institute provides an opportunity for scientists and stakeholders with different backgrounds around the world to learn from each other and ultimately advance our understanding of autism. All Summer Institute sessions are free and accessible to attend live to anyone who has created a MyINSAR account. Sessions will be recorded and available for replay following the conclusion of the entire series. This speaker session features a presentation from Dr. Jennifer Singh. During today's presentation, we hope that you will gain a better understanding of structural inequalities in autism research. We want you to learn about the range of quantitative and qualitative autism disparities research, identify autism disparities that exist within multiple axes of inequality, including gender, race, ethnicity, and social class. We want you to understand how structural and institutional inequalities shape autism disparities, and also become familiar with gendered politics with Medicaid. Before we get started, know that you can ask questions for Dr. Singh at any time. We will leave plenty of time for discussion during the back half of the session. If you wish to ask a question at any time, please use the chat window on the bottom left hand of your screen, and we'll get to as many questions as possible during the discussion period. At the very end of the session, we will leave a few minutes to talk about career development. I know Dr. Singh is going to discuss her career development during her presentation, and then if we have time, we'll also address specific questions to that as well. So please post your questions in the chat window, and we'll incorporate them in our discussion. I see that we're getting a couple of questions about audio issues and microphone stuff, and so we'll kind of work on that as well. We'll hopefully get everything sorted out before we really get started in a second here. Know that there are background materials for today's talk. If you haven't already, you can download these now at autism-insar.org. These materials define some of the key terms and provide suggested reading literature, as well as provide the learning objectives for today's session. Today's session was put together by Dr. Singh herself, and the materials she also helps with those as well. But I also would like to thank Soumya, who is our Student Training Committee liaison, who helped her organize the presentation and get everything going. So Soumya, thank you so much. Today we were going to have Dr. Soumya Shri Meyer-Kukur to introduce Dr. Singh and do a question and answer section, but we're having some trouble getting her on the line. And so we're going to take a minute to do that in a second while Dr. Singh is presenting. But Soumya will likely come on at the back end of the session and do the question and run the question and answer section. So, but I want to send out a huge thanks to her for doing this. I am now going to introduce Dr. Singh herself. We are so excited to have her with for this presentation. I think she's really adding a lot to the Summer Institute series. So Jennifer Singh is an Associate Professor of Sociology in the School of History and Sociology at Georgia Institute of Technology. She's the author of the book Multiple Autisms, Spectrums of Advocacy and Genomic Science. This book explores a range of perspectives from scientists, activists, parents, and people with autism surrounding the rise and implementation of autism genetics research. Her current research investigates the quality of care provided by a community-based autism clinic that serves underprivileged communities, as well as the social and structural barriers to autism diagnosis and services. I'm now going to turn over the mic to Dr. Jennifer Singh for her talk entitled Structured Inequalities in ASD Diagnosis and Services at the Intersection of Class, Race, and Gender. Thank you for joining us, and welcome, Jennifer.
Good afternoon, everyone. Can you hear me? Hello? Can you hear me?
Yes, I believe so.
Okay, just checking. Okay. Well, I wanted to thank everyone involved first at the INSAR Summer Institute and the invitation to present research on autism disparities in this wonderful series. And just a little bit about myself. Let me move forward here. This is the title of my talk. Okay, I'm just figuring out how to work this. Here we go. All right. I'm an associate professor of sociology at Georgia Tech in the School of History and Sociology, and I study the sociology of medicine, health, science, and technology. And I'm going to start first with my career pathway, which is not very typical. I'll start by saying that my favorite courses in college were biology, health, and sociology. I know we have lots of interests when we're young, and those interests continue as we grow older. My first career trajectory was just after college. It was working in the biotech industry in San Francisco, and I started in a lab doing experimental cell culture processing of recombinant proteins. This was at Genentech. And later I worked several years in the Department of Molecular Biology, engineering recombinant DNA and cell lines that express human proteins of potential therapeutic use. And while I was working in the field, I began to really ask myself questions about ethical and social questions about the potential impact these emergent drugs were having on people living with disease and the implications of our research for medical practices. Further, even though the trope at these big meetings that or these big parties that we would have in the biotech industry, we were quote unquote saving lives, with these new recombinant proteins. What I found was that no one was really questioning the inequalities of the U.S. healthcare system that would really make these molecules we were designing and manufacturing largely inaccessible to most patients. And so this led me to seek a master's degree in public health that focused on the ethical and the legal and the social implications of integrating genetics into public health research and practice. And so this is around the turn of the century, 2000. This MPH program at the University of Washington really started as a result of the sequencing of the human genome and the much anticipated application of genetics research on an understanding of the prevention of many diseases. And after I learned about, going through the program and learning about the science of epidemiology, health services, and biostatistics, I spent a year working at the CDC in the Office of Genomics and Disease Prevention, and that's actually what originally brought me to Atlanta. While I was at the CDC, I worked on various projects including evaluation guidelines for best practices of genetic testing based on current evidence. And despite the knowledge and experience that I had gained through my master's, I really felt that I was still in need of critical tools to answer more complex questions surrounding biomedical research. And this really led me to a degree in sociology that focused on medicine, health, science, and technology at UC San Francisco. And so it's here that I started working on autism research with a multidisciplinary team at Stanford University, where we were investigating social, cultural, and ethical implications of genetics research on neurological difference. and autism was our case study. And so that kind of gives you a brief trajectory of my career, and I'm happy to talk more about some of the nuances and things that I experienced during this time. So for the last 10 years or so, I've focused since this time at Stanford, I've focused my research on the social and the scientific implications of viewing autism through a genetic and increasingly genomic lens. And my recent book called Multiple Autisms, Spectrums of Advocacy and Genomic Science really maps out the social history of parental activism in autism genetics research, the scientific optimism and failure of finding a major gene for autism, and the various meanings attached to autism in the context of knowledge produced with emerging genomic technologies. And a major finding of that research was the ways in which biomedical frameworks tend to really obscure social and structural forces that shape how people experience autism, as well as their ability to navigate early diagnosis and subsequent services. Most notable among barriers facing those with autism and their families was this difficulty of securing a diagnosis. The lack of guidance given to parents after their child receives a diagnosis, and the limited resources available for subsequent services, which oftentimes is long-term. And this is particularly evident for families with limited resources. Okay. Another observation that I've made while investigating autism all these years has been the predominant face of caregivers of children with disabilities, which for autism has been represented as white, middle-class married couples who have time, money, and resources to achieve an early diagnosis and access very expensive and time-consuming therapies that could really make a difference in the life trajectory of a child with autism. So I don't know if any of you are familiar with the primetime television show Parenthood. It featured an upper middle white class family with a child, with a boy who had Asperger's, and so this is a less severe form of autism. The storyline portrayed a stay-at-home mother who was able to fiercely advocate for her son. She cut through the long wait list to get to see a specialist. She asserted her social and her cultural capital. And then the final season showcased these parents who live in the Bay Area as starting a new school for children with disabilities so that their son could receive the best possible education. And the executive producer of the show, who has a son with autism, stated that this portrayal was meant to really capture how parents deal with having a child on the autism spectrum and everything that they have to go through. And I was actually watching Netflix last night, and I don't know for those of you who watch it, there's actually a new show now. It's called Atypical. And the first thing I noticed again was how they highlighted white, educated, upper middle class families negotiating life with their teenage son with autism. Excuse me. In scholarly research, including my own, as well as many autobiographical accounts of parenting a child with autism, there's also many representations of mothers as warrior heroes who engage and fulfill the various social and biomedical accountabilities that they need to help their children. And these mothers have, social and financial resources to seek early diagnosis, gain expertise, and knowledge to help their children. And in some cases, I'm thinking of Jenny McCarthy here, really challenge approaches and expertise of professionals from multiple domains. And although these voices although these are the voices heard in mainstream culture, they aren't necessarily voices from experiences that are shaped in a structurally unequal society. And as Amy Sosa asserts, waging war on autism is expensive. It requires time and money to navigate and engage in such a war. It's estimated that the cost for autism services can range from $20,000 to $40,000 a year. And this doesn't really account for the unpaid labor, which is taken up by mothers, typically by mothers who coordinate all their child's care. And I'll talk more about that in a minute. So my research, this new research is really formed by the analytic framework of intersectionality, and this was developed by Black feminist scholars. I'm interested in calling attention to the centrality of white female experiences in autism parenting and how this narrow scope of this dominant conception of parenting tends to marginalize those whose experiences cannot really be described within these parameters. This approach, this intersectional approach, really attempts to analyze social relations and processes across multiple domains and levels of social action that are often typically investigated separately, such as race or class or ethnicity, but they should be looking at, as intersecting together. It considers how overlapping or intersecting identities such as race, social class, and gender contribute to to specific types of systematic oppression and discrimination that people experience in their everyday lives. This framework really challenges me to ask a new set of questions. So for my first study, I did interview many parents, but these were parents who participated in genetics research, so they were already connected to clinical, academic research institutes. So they were already hooked in and able to, part of participating in research was having knowledge that these research, trials and research opportunities existed in the first place. And so with this project, I'm challenged to ask a new set of questions, such as what happens when we begin to understand autism from alternative points of view, or ones that don't follow the archetype we see in our social and cultural landscape? And what can we learn from knowledge generated through these somewhat invisible perspectives with regard to structural inequalities? And how do these different ways of knowing intersect with race, social class, and gender? And what does this lens really tell us about structural inequalities and how they're embedded in the experiences of autism disparities? So the research that I will be sharing with you today really illuminates really illuminates voices that are typically silent from dominant narratives of autism caregivers, as I demonstrated earlier. And these are of Black women whose multiply burdened experiences are shaped by structural inequalities, and whose voices are often marginalized, obscured, and less understood. Okay, so let's see. Let me go back here. So this research is situated in a larger project that I've been working on in collaboration with the Children's Healthcare of Atlanta and Morehouse School of Medicine. And I'll discuss this project in a little bit more detail shortly. It's designed to take a multi-level approach to understand autism disparities that exist at this intersection of race, class, and gender. And I just want to highlight earlier, I viewed several of the webinars, that my research is less prescriptive in terms of how we can reduce autism disparities through this particular intervention or programs, but rather it's an investigation on why these disparities exist in the first place from a sociological perspective, and with the hope that maybe there's a way, if we understand the why, we might be able to shift the markers of intervention strategies. Okay, so for the rest of my talk, this is just a roadmap. First, I just want to provide a background on autism spectrum disorder and an analysis of autism disparities based on current research. So what do we really know about disparities? I'll then share with you the theoretical and conceptual model that I developed to conduct a multi-level analysis of autism disparities at the intersection of race, class, and gender. I'll briefly describe my methods that I use to generate the qualitative data that I'm going to share with you today. And finally, I will highlight narratives of structural and institutional inequalities based on these interviews. These are of Black women who are navigating autism services in the terrain of limited resources. And then I want to conclude, because we're talking about structure, just really highlighting the gendered politics of Medicaid. So when we're thinking about systems of care, how they're discriminatory based on gender. So, all right, autism disparities. What do we know? Or just autism spectrum disorder, really. Let's start off with that. So as many of you know by now, over the last 40 years, the recorded prevalence of autism in the U.S. has risen dramatically from a rare condition affecting 4 and 5 cases per 10,000 children in the 60s and 70s to a prevalence of 1 in 68 children diagnosed with autism spectrum disorder today. And I'm sure you can have a whole summer institute just on diagnosis. So there's a lot of reasons and why we're seeing these shifts. ASD is defined by the American Psychiatric Association as a lifelong neurodevelopmental disorder that's characterized by persistent deficits in social communication and social interaction and restricted repetitive patterns of behavior, interest, and activities. Now that's just one definition. There's also many more. A trained clinician can diagnose ASD reliably by age 2, and statistics suggest that it's 4.5 times more common in boys compared to girls. Recommended treatment for autism consists of early intensive behavioral and education interventions at a minimum of 25 hours a week, 12 months a year, which could potentially result in a child's ability to participate in education, community, and family life. Okay, so however, many families who have a child with autism are unable to access an early diagnosis and subsequent services, which has been associated with social factors such as socioeconomic status, race, and ethnicity. So there's a lot of data to support that. So for example, the most recent data generated from the Autism and Developmental Disabilities Monitoring Network at the CDC found that white children were approximately 30% more likely to be identified with an autism spectrum disorder than black children, and almost 50% more likely to be identified with ASD than Hispanic children. So in short, African American and Latino children are less likely to be diagnosed with autism. Quantitative research has also shown that these disparities are evident in multiple domains of autism trajectories, and these include age at diagnosis, access to early intervention and services, as well as representation of racially diverse students in special education. In fact, an analysis of data from the National Survey of Children's Health from 2003 to 2004, that they found that being autistic and black, Latino, or poor was associated with decreased access in all parameters of care that they examined, and this included specialty care, a personal clinician, having a primary care physician, clinical advice over the telephone, and timely acute care as well as preventive care. And that research, I think, is one of the background materials I provided for you. For those of you who can better visualize disparities by numbers, or who have witnessed the impact of individual therapies that individual therapies can really have on the developmental trajectory of children with autism, a longitudinal study of children referred for diagnosis of ASD at age 2 identified that the number of hours of individual treatment differed significantly by race. And so this study, which sampled children from 2 state-funded TEACH programs in the U.S., found that by age 9, Caucasian children had received on average 1,856 hours more of individual therapies from the time that they were diagnosed than had African American children. And by age 14, they had received 1,958 more hours of individual therapy. After reading this study, I just couldn't help but ask myself, what difference would 2,000 hours of individual therapy make for a child with autism, not to mention the impact that this would have on their families? More importantly, why are we seeing such huge disparities based on race and ethnicity? I think I was really surprised by that study. So many scholars argue that cultural differences account for autism disparities among Latino and African American communities, and these include cultural beliefs or perceptions about child development, behavior, or the nature of a child's disability. So for example, a recent study examined the differences between Latino and Anglo mothers in the type and the extent of autism-related concerns about their children. They found that Anglo mothers tended to report more autism symptoms than Latino mothers, specifically in the area of communication. The authors suggest that this is a result of Latino cultural beliefs about child rearing that might mask autism symptoms exhibited by their children and their recognition of it, so being able to identify that there is a delay. Research also indicates that although Latino and African American children are less likely to be diagnosed with autism, those that have a diagnosis have more severe symptoms compared to non-minority children. A reason for this disparity is also relegated to culture, indicating that less severe communication delays may be undetected or presumed quote-unquote unremarkable by parents of minorities. So although cultural barriers may contribute to some of the disparities we see in autism, another plausible explanation can really be related to the availability of flexible resources. And these can include things such as money, knowledge, prestige, power, social networks, so beneficial social connections. And so I draw on this idea based on the theory of fundamental causes, which is pretty well known in the field of sociology. It was developed by Bruce Link and Joe Phelan at Columbia University. And they posit that the persistent association that we've seen between socioeconomic status and mortality rates, despite significant historical changes in diseases, must be related to social conditions related to one's social class or socioeconomic status. And that this, socioeconomic status comprises of a range of these flexible resources. This theory seems to hold true for autism research. So for example, there is a lot of quantitative data to support it. The positive association between high socioeconomic status and prevalence of autism. So we're seeing if you have a higher socioeconomic status, you have your children are diagnosed earlier age, and there's earlier age at diagnosis. There's higher satisfaction with the process of diagnosis and services. Important work by Sandy Magana and her colleagues also show that education and number of sources of knowledge about autism are resources that give parents the flexibility and advantage to advocate and access services. They found that Latino parents had limited access to a variety of resources to learn about autism compared to white parents, including friends, other parents, health professionals, books, magazines, and the internet. And certainly, having these materials available in Spanish and other languages affects that ability to access as well. So with regard to community and neighborhood factors, sociological research by Peter Bierman and his colleagues at Columbia University have demonstrated that there is that social influence of information diffusion as well as neighborhood resources contributed to the increased prevalence, spatial clustering, and decreasing age of autism diagnosis. So their research is in California. So they're looking at populations in California. And their first study just showed that children living in a very close proximity to another child that had been previously diagnosed with autism, so say your kids go to the same preschool or you live in the same neighborhood or they're your neighbor, are significantly more likely to be diagnosed with autism than are comparable children who don't lack that exposure. The exposure being someone who has a child with autism. They conclude that this finding is just a result through the diffusion of information about autism through social networks, which are becoming more prevalent now, especially when we're thinking about social media. More specifically, social interactions are strongly conditioned by the distance between individuals, which are structurally located. In a related study, this group also demonstrated how socioeconomic status influences community-level resources that in turn drive the increase in prevalence of autism. This second study showed that higher levels of parental education and parental economic resources were consistently associated with an increased likelihood of diagnosis. But more importantly, they show that the effects of neighborhood socioeconomic status, which can influence health in many ways through the physical environment, are there toxins around the social environment, are there parks, are there places that are safe for families to go to, and then also the neighborhood socioeconomic status is influenced by the way in which different communities have structures that enable or prevent access to medical care and services. And these connections between neighborhood socioeconomic status and access to diagnosis remain strong over time for children born to parents with fewer resources. And so we're seeing a lot of evidence here. Health policy and other state and federal policies matter too. I don't know how many folks study health policy that are on the line, but this is important to think about as well. So for example, a quantitative analysis of Medicaid claims of children in Philadelphia found that Black children who received specialty mental health services through Medicaid required more time in treatment before receiving an autism diagnosis. They were also about 2.5 times more likely than white children to receive a diagnosis on their first specialty care visit. So we're seeing differences through Medicaid recipients. A national study also showed that families living in states with higher per capita Medicaid spending for children with disabilities were significantly less likely to report financial burden. With regard to immigration policy, Peter Bierman's group, which I mentioned before, showed that how there's just temporal patterns of autism diagnosis, so it changes for Hispanic children in California because they're linked to state and federal anti-immigration policy. So we're seeing how immigration policy affects whether or not someone can get services. This limits access to public services for undocumented immigrants and their families. Okay, so these quantitative studies just really begin to draw on important connections between autism diagnosis rates by situating their analysis within structural and social context. Further, these studies really begin to conceptualize health disparities at the structural level by taking into account how the availability of neighborhood and community resources contribute to increased prevalence of autism, and the influences of public policies on access and utilization of autism diagnosis and services. Moreover, this research really begins to unravel the structural and the interacting mechanisms of inequality based on ethnicity, which clearly demonstrates how power is organized, distributed, and maintained within state and federal policies. Okay. So I just wanted to briefly review some of the qualitative research, which there is not nearly as much as quantitative research. And although quantitative research has been useful and in some cases draws attention to these larger structural inequalities, this research fails to inform us of the experience of learning about and living with autism, nor does this research illuminate how people experience and negotiate autism and autism services unequally. So as a qualitative sociologist, I was surprised to learn that there's less, qualitative research is less represented in the literature on autism disparities, based on interviews with medical and educational professionals who actually work with underserved communities, as well as, minority families, Latino, African American, or low socioeconomic status families who have a child with autism. Research thus far, or qualitative research, is important because it really has the potential to offer a more nuanced and a contextualized understanding of what really places children at risk of receiving a delayed or misdiagnosis or encountering barriers to early intervention or therapies or special educational services. And qualitative research also allows for attention to be drawn to larger historical, social, and cultural contexts, as well as, not to mention, the lived experiences that people actually have, whether it be people who have autism themselves or the families that have children with autism. The qualitative research conducted to date has really revealed important discoveries. So for example, qualitative studies based on focus group and interviews with families with Latino children previously diagnosed with autism found that Latino parents had little information or sources of knowledge about autism. Community members were uncomfortable talking about autism due to stigma associated with mental health, and providers sometimes dismissed parent concerns or did not understand their children. Qualitative research based on interviews with African American parents of a child with autism is even less represented in the literature. Work by Olga Solomon and colleagues has really begun to provide important insights in this limited area of research. Based on interviews with African American mothers of children with autism, these authors show how African American children and their families are marginalized and treated unequally by institutions authorizing autism-related services. Furthermore, what's nice about her research is that they draw on multiple perspectives, including parents, practitioners, and clinical observations. Her work demonstrates how African American parents experience the clinical portrayals of their children and themselves in health records. So she looks at health records to see how portrayals of people are manifested, which they argue tacitly ratify or negate how parents portray their children. Okay, so I realize that this is a lot of research to cover in such a short time, and it's been overwhelming for me to think about the range of research that exists in autism disparities and how different approaches are being taken and ways that we're thinking about this. But the take-home message is that collectively these quantitative and qualitative studies demonstrate a clear connection between access to flexible resources and the ability to navigate and obtain autism services. They also really call attention to the national disparities in multiple domains of autism, healthcare that exists at the intersections of race, ethnicity, and social class. And furthermore, as many autism experts have already asserted, they challenge us to really consider a more comprehensive and system-level explanation, along with the development of interventions that address racial and ethnic disparities in autism healthcare access and quality beyond differences in parent beliefs and or culture. Okay. So next I just want to tell you a little bit about the study that I'm doing that builds on this research. I'm conducting a mixed method approach in order to identify and theorize different levels of inequality that are contributing to autism disparities at the intersection of race, class, and gender. And as I indicated before, this research is informed by the framework of intersectionality, which really conceptualizes various dimensions of inequality. And these could be based on racism, sexism, classism, as they are intersecting relations of power. These forces additionally create a basis for identity and group status. I mean, we can all relate to being in one of these categories or all of them, and they form different levels of hierarchy in terms of difference. Analytically, this framework interrogates how race, class, and gender and other social locations operate simultaneously in social life rather than working as a single category. So if I'm looking at autism as disparities, maybe looking at race just isn't enough. We need to look at other categories as well. Importantly, it acknowledges how power is organized and distributed, maintained, and challenged based on these intersecting social categories. So this framework, it's been taken up within several disciplines, such as public health, gender studies, social work, media studies, anthropology. So sociologists have also used this conceptual framework to investigate various axes of inequality, including health disparities in diseases such as HIV, AIDS, and heart disease. And these studies really highlight the social context of quote-unquote risk, right? So what puts people at risk? And the inextricable link between health behaviors and outcomes. So if someone has a low health outcome, whatever it might be, whatever measure that might be, how those individual measures are linked to structural, historical, and situational contexts of people's lives as they are shaped by race, class, and gender. And I just want to talk a little bit about why I would even think about gender in this analysis. So the inclusion of gender in thinking about this research project is related to, and how it might be related to disparities of autism, is particularly important for us to consider since the social science literature, feminist literature, disability studies typically show that mothers are the primary caretakers of children, especially children with disabilities. The inclusion of gender in this analysis is also a unique contribution to autism research since explicitly it's really not been seriously addressed in terms of theorizing autism disparities in diagnosis and services. And as I indicated earlier, in the dominant model of autism parenting, there's this assumption that mothers have the time and the resources to really navigate various autism trajectories of care over time. Further, the narratives in scholarship and in public domain, often stories of highly resourced white, upper middle class, and married women. So my research really takes into account the intersecting and multiple impacts gender has for Black women who may be navigating autism services on their own. And thus this analysis reveals the workings of social class as articulated through race relations, as it explores why these women may have limited time due to work commitments, or maybe they just have limited sources of social, economic, or cultural capital. So drawing on an intersectional approach, I developed this conceptual framework and methodological approach to advance the understanding of autism disparities at 3 levels of analysis. And I have this circled here, and I think I have fancy little tools here in red. These are the structural, the institutional, and individual levels which intersect, at the axes of race, class, and gender. So these 3 levels of analysis were drawn and elaborated by work that was done on intersectionality and HIV/AIDS, as well as thinking about the theory of fundamental causes that I mentioned earlier. The structural level, just to kind of give you an idea, well, what does structure really mean? This consists of customs, practices, or laws that shape health disparities, and these can be historical segregation laws, which affect housing, which affect education. These could be healthcare policy laws, special education laws that restrict or deny access to services. So for example, state programs such as Medicaid health insurance or early intervention programs like Babies Can't Wait in Georgia, here in Georgia, can potentially shape who has access to autism services, the type of services that are offered, or the overall spending for children with autism or children with disabilities more broadly. This is particularly relevant in Georgia since we're one of the several states that didn't take up Medicaid expansion through the Affordable Care Act, commonly known as Obamacare. At the institutional level, this is based on differential access to goods, services, and opportunities of society. And these are in interaction and influenced by structural inequalities, and these can include material conditions such as quality of education, sound and safe housing or appropriate medical facilities, or access to grocery stores, and the ability to access power. And so power can be in many different forms. This could be knowledge, this could be resources, and as well as representation in terms of do people have a voice when it comes to setting policies around Medicaid, for example. So for example, families who do not have access to quality health care because of structural inequalities, they may miss opportunities for a pediatrician to identify a developmental delay. And the individual or interpersonal level really operates at the level of personal interaction, and this could be in the form of discrimination of various forms, trust, reciprocity, stigma, and especially things like language barriers, which can really shape health behaviors and individual health outcomes. So for example, research shows that African American children were 3 times more likely to receive another diagnosis first before autism, and were 5 times more likely than white children to receive a misdiagnosis of conduct disorder or adjustment disorder rather than ADHD, which is attention deficit hyperactivity disorder. So these findings suggest that there's racial prejudices and discriminations held by clinicians that can affect the probability of one diagnosis over another, as well as referral bias in pediatric assessment of autism in ethnic minorities. Okay, I'm going to turn this off. So as you can see from this figure, interviews with caregivers is just one part of the larger mixed method study that I'm doing to investigate these various levels of inequalities. And to be frank, sometimes it gets a little overwhelming to try to think about these different levels of analysis. In addition to a caregiver quality of survey that I've just completed, I'm also gathering qualitative interview data from social and cultural brokers. These are folks that are intermediaries and help families navigate, or they can even be called navigators. I'm interviewing service providers who really directly provide services on various levels to families of children with autism who are underserved, and then clinic providers as well. Okay. let's keep going here. Whoops. Back up a bit. So the data I'm sharing with you today, it was collected in collaboration with Dr. Leslie Rubin. So he's the director of the Autism Clinic at Hugh Spalding Hospital. So this is a campus of Children's Healthcare of Atlanta, which is the largest Medicaid provider in Georgia at Hugh Spalding. And at Hugh Spalding, 90% of the patients are uninsured or rely on Medicaid. So my analysis is based on demographic data from a quality of care survey that we did, as well as in-depth interviews that I conducted with primary caregivers who have a child who receives services at the Autism Clinic. I'm happy to talk more about the survey and some of those results in the Q&A. Essentially, we measured 3 levels of quality of care. But throughout the survey, I asked open-ended questions to really better understand the survey responses, as well as questions designed to understand caregiver challenges and the experiences that they had before, during, and after their child received a diagnosis. So for today's talk, in terms of thinking about data that we've collected, I'm going to be drawing from 13 caregiver interviews. I've actually conducted 60, but this analysis is new, and the analysis is ongoing. And I did this using grounded theory methods. I'm happy to talk more about that. But today I'll provide an analysis of the structural and institutional qualities that were evident in the narratives of these 13 women. So these are 13 families, and these were either mothers or grandmothers who were raising a child with an autism diagnosis. And I show how these narratives really are embodied at the intersection of race, class, and gender, and that they're situated in structural and institutional inequalities, which I argue shape the risk and experience of autism disparities. For someone who's been studying autism for such a long time, a lot of these experiences I had never heard before or hadn't really thought about it in the context of the lives that they were living. So I believe that these narratives really offer an alternative or a different story compared to the dominant portrayal of caregiving that we've seen thus far. So a little bit of data. This just gives you a snapshot of the demographics of the 13 caregivers who participated in the study. 70% consisted of primary caregivers who were divorced or never married. 9 were mothers, 4 were grandmothers. We have 62% of the women had high school graduation. Over half of the participants rented an apartment or home or had an income less than $40,000 a year. All the families were English speaking, and Medicaid, let's see, 70% were on Medicaid. Importantly, too, for today's talk, half of the participants rely or have relied on public transportation, and I believe 61% were unemployed. So it just kind of gives you an idea of the demographics. The second chart shows shows the average age of the child with autism in these families. It was 8.7 years old. The range was 3 to 15. The average age of diagnosis was 4.8 years old. The time to diagnosis from when a parent was first concerned, well, on average it was 3.1 years. So this is the time it took from the time a person was concerned to when they actually got a diagnosis. So in this case it took 3 years on average to get a diagnosis. Okay, these demographics and others were really collected to help understand the various dimensions of social class, which can help us contextualize the risk of delayed diagnosis and limited access to services. And so really to help understand these gaps more comprehensively, I'll offer you some narratives. Okay. And this is the data I find most interesting, obviously. So structural inequalities that are evident in the data thus far circulate around issues of government systems of care, work policies, income inequality, as well as the quality of schools. These structural inequalities do not operate in isolation, but rather work together and interact with race, social class, and gender, as evident in the cases that I'll share with you today. So So for example, families in Georgia, as well as other states, they must negotiate a range of federal, state, and private financial resources, as well as coordinate care among numerous providers. This could be educational, medical, therapeutic, in order to access the care needed for their child with autism. As previously noted, all the participants in this study were women who overwhelmingly expressed to me that they did the majority, if not all, the care coordination in order to get therapeutic and educational services that they needed for their child. So government health policies, especially Medicaid, serves as a structural inequality since it covers a limited amount of autism therapies here in Georgia. And this affects how many services caregivers can feasibly obtain. So for example, Tiana, a Black single mother who has 4 children, she works full-time and has a 5-year-old boy diagnosed with autism. I met Tiana during her 30-minute lunch hour at work, and her most recent concern was trying to find an occupational therapist for her son. She was frustrated because all the Medicaid referrals she received from the autism clinic that were in her geographic location were booked and did not even have a wait list. She stated, quote, "When I called to schedule an appointment, they said they were booked. There was no waiting list, and they didn't even have anyone who could see him because I wanted later hours," end quote. So for Tiana, having availability to therapy offered in the evening and closer to her home would have made it more possible for her to get the services recommended for her son. The limits of services were also evident in her son's school, which only offered speech therapy once a week, even though the clinic recommended that her son get at least 2 speech therapist sessions a week to help with his ability to verbally communicate. He wasn't yet talking. Even though there are other private speech therapy options outside of school or Medicaid, Tiana can obviously not afford them. And even if she could, she would not be able to take time off of work because the sessions are typically offered during the day. Furthermore, she could not feasibly travel over an hour each way to make her son, or to take her son to these other services twice a week that are available in other parts of Georgia because, I don't know, there's a lot of traffic in Georgia for one, but because she has other children to care for and she works full time. So for now, she goes to an additional speech therapy that's offered 1 day a month on Saturdays near her home. However, she has to take all her children to these sessions, which can be difficult since these places are not typically equipped to accommodate siblings. So Tiana's story of trying to get 2 of the most common autism therapies, speech and occupational, highlight the various structural inequalities, such as limits of Medicaid coverage and service availability of special education services. These intersect with constraints in her time, the caregiver time, and resources to get the help her sons need. Tiana's full-time job as a janitor provides her with a stable income of $25,000 a year, so this allows her to rent a home and provide for her family. However, her full-time job also serves as a structural barrier due to the inflexibility of her work schedule, which is typical for service industry workers because you can be paid just by the hour. Several of the women I interviewed really struggled with this inflexibility of their job to leave during the day and to take their children to their therapies. Having a full-time job was also constraining, especially for women who would get penalized when they had to leave at a moment's notice. You know, women told me stories how they would get calls from the school saying you need to come and pick up your son. And so this would impact their ability to work. The limits of Medicaid in Georgia are also evident based on caregivers who have received state services in places like New York and Maine. So it's been really interesting to talk to families who actually moved here and had an experience elsewhere and to make a comparison. So take Alicia, for example. So Alicia's married and a stay-at-home mom. She used to work but got fired because of the frequent times she had to leave work to care for her 2 daughters. One has autism and the other has bipolar schizophrenia. She moved to Atlanta with her husband and 2 daughters because 13 months ago, after her husband lost his job in Maine, they thought that Atlanta would be a good place to relocate since her sister lived here with their children. However, she described how obtaining services through Medicaid in Atlanta are extremely difficult to access and limited compared to her experience with Maine's healthcare system. While living in Maine, Alicia had access to a range of services for her daughter that came to her house directly, such as speech therapy, occupational therapy, physical therapy, social skills, and adaptive therapy. Her daughter also had access to small and large groups to help with her socialization skills. All these services worked both inside and outside the public school system and coordinated together. This was extremely beneficial, especially for Alicia, who doesn't have access to a car and has to rely on public transportation. She described how services offered in the home created a more holistic approach that not only offered services to the child with autism, but also provided parents with tools needed to help their children in the environment available to them at home. So like Tiana, Alicia was also very frustrated with the amount of effort it took to get Medicaid services when she first moved to Atlanta, where many services were not available and caregivers are responsible for coordinating all the care, which is spread out in many different physical locations. She said, quote, "It's a roadblock. Every time you are trying to get speech started or trying to get occupational therapy started, there's a long wait list for everything. So really, I think the biggest problem is delay in everything. And you have a kid that is now going without services because everything is so delayed. And then they start having regressive behaviors because they're not keeping up with the skills that they are learning, that they were learning, and they're losing them." So Alicia went on to discuss and share with me that even when she finally secured therapy for her daughter, she has to be really careful not to go over the caps that Medicaid would cover, and that if she goes over the coverage, it would be hard for her to pay out of pocket for the difference. To help resolve this, she requested guidelines from the Medicaid office, and she said she wanted to show it to me. She received this giant, thick document written in legal language, which obviously she could not understand or comprehend. So I have another example, but I think I'm going to move forward just in this for the sake of time. So these examples are just a sample of the structural constraints that exist for parents who have limited resources and rely on Medicaid. There's layers of complexity here which do not point to a single barrier, but rather structural inequalities embedded in Medicaid insurance policies and services, limits of inner city public schools, which are also racially divided here in Georgia, flexibility of work policies, and income inequality. The fragmented systems of care in the state of Georgia and the amount of work required gaining access to government programs and special education services are structural constraints that are compounded, I argue, for low-income and Black female caregivers who are typically doing all the coordination of care with limited resources. Families, so this is a little bit more in terms of the location of where I'm situated. Families who live in South Fulton County, for example, disproportionately experience many challenges finding autism services south of Interstate I-20, which cuts right across Georgia. Historically, this I-20 was a dividing line that segregated communities based on race and social class. In fact, the clinic where I'm working and learning from families is situated very close to this dividing line and operates in the shadow of Grady Hospital, which is the only public hospital we have in Atlanta. Okay. So institutional inequalities, again, these are based on differential access to goods, services, and opportunities of society, and they're intricately related to structural inequalities. Are also very evident in the data so far. And I just want to highlight for you barriers of transportation and the ways in which this institutional inequality manifests differently for the families that I've interviewed who have children with autism. So the institutional constraints of transportation were a concern for several of the caregivers that I have talked to. It relates to Alicia and other caregivers' criticisms of how services in Atlanta are not offered in one place, as well as Tiana's frustration with the far distance parents are required to travel to get to the only services available. Half of the caregivers in this study so far have had to rely at some point on public transportation to get to and from autism services. Compounded with the constraints of Medicaid, the lack of reliable transportation limits what service caregivers have access to. not to mention the time that it takes to get somewhere. And I don't know if any of you take public transportation. I think you can safely say that many times it does take longer to take public transportation. So for example, Alicia, who I highlighted earlier, described how she could only seek services for her daughters that were within close proximity to home and to public transportation. And so this significantly limited her options. She also emphasized that if she had to work, it would be impossible to manage the care for her daughters. The time lost when caregivers have to rely on public transportation is tremendous. So on various occasions, I can recall seeing young mothers at the clinic with their children waiting for the Medicaid transportation service. And this is a picture of it here. Sometimes for more than an hour. This was troubling to witness since most clinic visits, at least from my observation, take about 2 or 3 hours. And to add more time because of the constraints of public transportation, this can be very stressful for both caregivers and their children. So several of the mothers that I interviewed shared with me their experience with the Medicaid transportation service, describing it as both unreliable and slow. So Paula, who I mentioned, you didn't meet Paula, but she is also part of this study. She's married and has a daughter on the autism spectrum. She described to me how this service sometimes doesn't pick you up, she recalled. They took you to a location, but they didn't come back to get you. I can remember being downstairs at Hugh Spalding waiting for services, waiting for the Medicaid bus for 6 hours, and wondering how in the world was I going to get home. We had just moved here. We didn't have a vehicle, and my husband hadn't started working yet. It was hard finding a job because you need a vehicle to drive to the interviews, so that was a major issue, and that became a huge problem. Paula finds the unreliability of this service extremely stressful because she has to coordinate ahead of time someone who can take care of her children if she's running late because she has more than one child. She also felt that at a disadvantage because on several occasions she was unable to take advantage of an appointment for services that came up at the last minute because she couldn't get a ride to the desired location. Medicaid transportation requires that the reservations be made several days in advance, for example. The logistics of these types of situations only adds to the already complex situation of these caregivers' lives and ability to navigate services. Caregivers who have to rely on public transportation also have to manage the challenges of having a child with autism in public. This is something that we hear often about, but maybe not in this particular context. Autism is often described as an invisible disability because on the surface, children with autism seem like other typical children, especially if they don't move their bodies in particular ways or make unusual vocal noises. Parents have reported getting blamed for being a bad parent or accused of not disciplining their child when their children have emotional or behavioral outbursts in public. So this is compounded when people have to rely on public transportation, as you can imagine. So for example, one grandmother, she is the primary caregiver of her 3-year-old grandson, shared with me how hard it was to take him on public transportation. She often feels judged by other people because her grandson is very active and occasionally has behavior tantrums. This is especially difficult because she relies on public transportation to get to town and consistently encounters people who just don't understand why her grandson is acting up. As her grandson has gotten bigger, she now has to put him on a harness when they're traveling using public transportation because he has the tendency to run off very quickly. So this is another way in which children manifest autism. As one can imagine, this elicits many stigmatizing responses, not to mention the stress that the caregiver must experience in these circumstances. So many of the children with autism are also very sensitive, as you may all know, to loud noises, crowded spaces, and particular odors, characteristics that are often associated with public transportation. So furthermore, children with autism often function better when their schedules are reliable and consistent, even in the specific routes in which they travel to and from particular places like school. I began to really think about these issues and the challenges that they must pose when taking public transportation. From one mother, her name's Sheila. So she was a single mom who just moved to Atlanta with her 2 teenage daughters. Her 15-year-old daughter was diagnosed with autism, and when we met, she was experiencing hormonal changes which had enhanced her daughter's behavioral issues, her level of anger, as well as her anxiety. On several occasions, Sheila and her daughter could not reach the clinic appointments because their daughter just refused to take public transportation. And Sheila reflected on this time by passionately stating, "Sometimes I have trouble with her getting on the train and on the bus. Sometimes she doesn't want to ride. Since the doctor has been helping with the medicine, it's not as bad as before. But before, I couldn't even take her on the bus. And when there was a whole bunch of people, because she would have these episodes where she thought people were just staring at her." And so the mom described it as really going through it. She says, I went through it. And so when I met Sheila, she was also living in public housing and told me that the first public housing accommodation they stayed in, when they moved to Atlanta, kicked them out because their daughter often screams or makes loud noises at night. Sheila's story really began, it brings a whole new dimension of the realities of autism for caregivers and their families who have neither reliable transportation nor housing. The stakes of having a child with autism in Sheila's case are much greater and the needs more complex. Unfortunately for Sheila, she moved to Atlanta thinking that she would be able to get better services for her daughter here based on the knowledge that she had read about on the internet about autism. Where she had lived before, her daughter received wrapped around services, including behavior support, social skills, and various services in her school. In Atlanta, her experience thus far had been, quite the opposite. Since when I met her, she was still trying to get both her daughters enrolled in school. The move also created a gap in her daughter's Medicaid insurance, which resulted in multiple trips to the emergency room where her daughter became extremely uncontrollable because she did not have access to her medications for anxiety. Okay. So I just want to conclude with this title of Rethinking Autism Disparities. So these stories really begin to make visible the complexity of Black women's lives who are raising a child with autism in a structurally unequal society. These narratives also reflect the embodied experience of living with structural and institutional forms of inequality that operate through and intersect with various forms of discrimination. Since most of the women I interviewed had to rely on public insurance, I'd just like to conclude by highlighting the intersectional and the gendered politics of Medicaid, which are evident in these and other stories from this sample. This is important because not only does the politics of Medicaid reflect the have-nots in American society who compose the program's clientele, it's intricately linked to issues of gender and race. So, for example, women are more likely than men to endure financial hardship, experience low-wage jobs lacking retirement and health benefits, and reside alone or in single-parent households. Marital status is a significant predictor of economic security, and women are far less likely to be married than men. So this is certainly turning out to be the case in my sample. Further, roughly 70% of the adult Medicaid population participants are women, and although Blacks compose 13% of the U.S. population, they make up roughly 1/4 of the welfare medicine participants. The quality of care is also limited, as evident in a report by the Institute of Medicine, which reviewed more than 100 studies pertaining to minorities and medical care. They found that insurance status, so whether someone had insurance or not, is strongly associated with the quality of services. That privately insured tended to receive better care than those who are insured through Medicaid. This is not surprising. Even when certain racial ethnic minorities have access to low-income health programs, they consistently experience fewer diagnostic and other routine services than do other sectors of society. So for the mothers and the grandmothers on Medicaid in this sample, the ripple effects of the intersectional and structural constraints of Medicaid have most certainly affected the life trajectories of their children with autism, as well as many other chronic health conditions. Certainly, this is just the tip of my analysis, which warrants a closer look at Medicaid policies in different states across America, especially when taking Medicaid expansion into consideration and the possible implications of the extraction of Obamacare. These actions are, of course, as we are witnessing now, part of a historical tug-of-war of Medicaid between Democratic and Republican leaders over its policies, procedures, and especially funding and benefit levels. As expressed by the voices of the women who shared these stories with me, the effects of such political debate really impacts the lives of people in very serious ways. So these findings just begin to offer alternative voices that disrupt the dominant narrative we have witnessed thus far of the experiences of parenting a child with autism. This analysis really begins to highlight the various structural and institutional inequalities that shape disparities in autism diagnosis and services, especially among low-income Black women who are navigating the complexity of autism services. It also highlights the various interlocking locations of social oppression that really cut across gender, racial, and class lines, which are experienced in very different ways to represent an alternative warrior mother who really has to challenge much larger structural constraints. And I guess I will just end there and want to acknowledge, so far I've interviewed 60 families. I want to acknowledge all the caregivers who have participated in this study and shared with me, their story, essentially. My collaborator at Morehouse School of Medicine, Dr. Leslie Rubin, the staff at the Autism Clinic at Hugh Spalding. We did receive a grant to do this research through a collaborative effort through Georgia Tech and Children's Healthcare of Atlanta, and my wonderful graduate student who's helped a lot with the survey data that I've done. And so I've covered a lot of ground, and I'm happy to take lots of questions, or if you have to leave and you'd like to call me or contact me, I'm more than welcome to take your questions. Thank you.
Thank you so much, Jennifer. We really, really appreciate the presentation. It was fantastic, and it definitely helped kind of alert my attention to some things I was unaware of. And I'm really excited for our question and answer section. We've gotten a lot of questions
okay,
so far.
Great.
So thank you. Yeah. So, and I also we figured out our technical difficulties, and so I need everyone to be a little patient for a second as I'm going to try and patch Soumya in. She is our she's our student trainee committee member who's going to run the question and answer section of our presentation today. So I'm going to try something.
Okay.
And Soumya, are you there?
Yeah, can you hear me?
Awesome, we can hear you. I will turn it over to you two. Soumya will be asking Dr. Jennifer Singh a few questions, and then she'll be responding. But keep your questions coming, because we will add them to our queue as we go.
Okay.
Thank you.
All right. Thank you, Dr. Jennifer Singh, for such a great presentation. And we have a few questions already lined up to your talk. So the first question is that in your handout, you define gender as the traits and behaviors that are socially designated as masculine or feminine in a particular society. Firstly, could we see that definition more in the direction of gender expression and not gender identity? Could you comment on some of the structural and systemic issues related to the fluidity of gender, especially for individuals on the autism spectrum, as we know that there is an established overlap between autism and gender diversity? More specifically, many autistic teens and adults may identify outside of the gender binary as gender queer, gender non-conforming, or agender, for example. So how does your research address this emerging finding around gender diversity within the autism spectrum?
Absolutely. So how does my research reflect the various dimensions of gender that exist in the autism community today? Is that a fair interpretation of the question?
Right, yes.
Yeah, that is a wonderful question. And issues of gender are never one or the other or a binary. And we took these definitions from, I asked Soumya, to take these definitions just from the sociology perspective, but certainly there are different ways we can think about gender that's different than sex, of course, where sex is more the biological differences between a male and a female, where gender are just different expressions of masculinity and femininity. And certainly there is emerging research that is looking from the perspective of people who are on the autism spectrum as neither or, masculine or feminine, or not defining as such. My research, this isn't something, I'm looking at gender within the context of the caregivers that I'm interviewing and not necessarily the gender of their child. Certainly that affects the concerns that they might have, particularly among the African American community if they have a male black child, and the type of discrimination that they already experience in their lives, and how having a disability or different levels of ability are going to affect their future. And so it's not something that is necessarily coming up, but there is research that I'm trying to think of who is doing this research that is really thinking about, and it's probably even coming from people who have autism themselves, who are asserting that they don't identify with either or. I don't know if that answers your question.
Yeah, I think so. Thank you. Well, the next question is, can you possibly talk about the barriers to autism diagnosis at the intersection for girls and women of color on the autism spectrum?
Okay. Could you slow down when you ask the question? So can I answer the value of an autism diagnosis?
Yeah, sure.
And was there a second part to that question?
Barriers to autism diagnosis at the intersection of race, class, and gender for girls and women of color on the autism spectrum.
Well, I think that's a really good question to think about, the value of an autism diagnosis, because there is certainly, the way I've described it before, it has capital. So getting a diagnosis opens up the doors to particular kinds of services, because autism is a specific condition that is defined as a disability in the Individuals with Disability and Education Act. So oftentimes people will come to the clinic because they need that particular diagnosis in order to qualify for a particular program or services. And so it certainly has a level of value in that regard. And I think it's a really good question to think, and it's something that I've been grappling with. So when we're looking at these disparities, and we learn, and as much as I know about the complexity of the autism diagnosis and just sort of the politics around defining people as, ably different or disabled, to what degree should people who are at the intersection of race, class, and gender maybe people don't want that diagnosis, right? Because it doesn't suit what they believe, might be a problem or not even a problem for their child. But and that's something that I'm grappling with right now and thinking about. But my experience, based on the observations that I've made and the interviews that I've done so far, is that having the autism diagnosis allows for a pathway to get special educational services, to get, especially, it depends, because there's such a variability in autism spectrum disorder in terms of what people are able to do at various different levels. There's a range of things that people can benefit from, whether it be speech, whether it be occupational, whether it be ABA. But what I'm finding is that the diagnosis is useful for this population, but because of where they're socially located, they're unable, so families who are on Medicaid cannot get applied behavioral analysis. They cannot get any kind of behavioral analysis because Medicaid does not cover it. And so their options are limited to what is available. So in that case, maybe the diagnosis only serves a little bit of benefit in terms of value. But I think for parents it can be a way in which to start thinking about the future in terms of a roadmap of what they can do. But that trajectory is shaped, it's shaped by people's location. Unfortunately, especially, I would like to look at these other states like Maine and New York. Families are telling me we're just really phenomenal in terms of the trajectory and access that they had, and how that's different depending on where you live. I hope that helps answer the question.
Right. So in some locations in the U.S. where supervised clinicians, meaning the clinicians who are not licensed and are still in training, are unable to see Medicaid or Medicare clients. There are also certain areas where mostly clinicians in training see clients with Medicaid. How do you think this might impact access to diagnosis or treatment?
So what you're saying is that residents in training, some residents in training will actually work with populations that are restricted to Medicaid, where other residents in training never have that exposure. Is that correct?
Yes. Yes.
And so the question is, how does this affect people's training? Yeah, that's or yes. Just like how would that affect whether or not does that contribute? So if a resident doesn't have exposure to families that are situated very differently than people who have health insurance and have access to these sorts of things, early diagnosis, and then ABA, for example, and that's what they know and that's what they see as the norm as the trajectory might happen. If a resident does not have access to families that have less resources, would they be able to, would that impact, would that help explain the disparity? Is that sort of the question that is being asked? I'm just trying to understand
it. How does this impact diagnosis or treatment for the family?
Yeah, I think so. The interesting thing is the clinic where I'm working, it wouldn't run without resident trainees. So they do a month rotation in developmental pediatrics, and they come to the clinic. And so I have actually interviewed all the residents that have come through. So, and this is part of my analysis that I haven't actually really started. But what I'm learning is that their experience coming to the clinic, they realize that there's so much more involved in terms. It's not just about the autism. There's families are in crisis. There's so many other, and you're dealing with families, right? Not just an individual. It has to be within the context of the family. And they, trainees tell me that they learn about all these different programs that they didn't know about before. So essentially, doing sort of social work, more type social work, the kinds of resources that families need to go to in order to get the services that they need. And so I think just having that knowledge and just trying to understand that people's lives are very complex. They aren't situated in one way, is extremely beneficial for a resident in training, and without that may come to a situation and maybe view a parent who doesn't get services when they were obviously told, your son needs to get or your daughter needs to get speech therapy twice a week or something like that, and not realize that the context in which this person has to get services are very complicated. And so not having that knowledge, and I think it's very important, I guess, at the bottom line, whether or not it doesn't have to necessarily be in autism. It could certainly be in other cases as well, because these structural inequalities exist. Autism is just a case study of it. So if residents have the opportunity to work in different communities to kind of see how the social location of people's lives really shape their experience, at the wherever they're getting care, and then what happens afterwards would be extremely beneficial. So if you can get that type of training, I would highly recommend it, because I've just seen from interviewing, I don't know, maybe 15 residents who've gone through this program, how beneficial it has been for them. I hope that answers the question.
Right. Yes, yes. Okay. What can clinicians do to reduce bias, especially when a child first presents with behavioral concerns?
I'm sorry, I'm having a hard time hearing you. Can you ask that question again?
What can clinicians do to reduce bias, especially when a child first presents with behavioral concerns?
So what can clinicians do to reduce bias, especially, what was the last part?
When a child presents with behavioral concerns.
Especially when there's behavioral concerns? Yeah.
Yeah. If a child is presenting
that's a really good question. And so I guess I'd want to understand that question a little bit more. So if a child comes in and has behavioral concerns, and because there is studies that show that there's bias based on a child's race, and whether you interpret that concern as adjustment disorder, behavioral conduct disorder, or ADHD, or something else, or maybe this child's on the spectrum. And I guess acknowledging and understanding that we all have biases, in the ways in which we interact with people, and as a clinician, understanding that these exist, because we're embedded in a culture that has built these built-in biases our whole lives. But I think the first start is just acknowledging that it exists, understanding that there's actually data to prove that it exists. Maybe reading those studies. I mean, I reference everything that I talked about in this paper or in this presentation, and then really making a conscious effort to not only think about your own practice when you're having interactions with families and the kind of biases that you bring to the table, and consistently think about how you can not be part of that, actually following through with it. And I think part of that is just understanding that it exists and that we all have these biases, and that interacting with people, and acknowledging that you might have a bias, and maybe you don't even realize it, but being aware that these exist, I think is the first start when it comes to that. I'm not a clinician, and I've never had to make those assumptions about people at that level of interaction. So this is just coming from observations and knowledge that I've learned from the literature.
Thank you. The next question is, how do you see your own gender and racial or ethnic identities impacting your research approaches, like outreach strategies, qualitative interviews, and how do families perceive your interest in their research experiences?
Mm-hmm. Yeah, so that's a really good question. So part of this type of research that I'm doing, which is coming from an intersectional perspective, and qualitative research, is really about being reflective of where I'm socially situated. So I identify as a heterosexual female who a mother. I am Latina, an Indian, and I recognize that I have a level of authority over all the families that I'm interviewing, because I have a high socioeconomic status. I have a PhD, a master's in public health, and a college degree, and a high school diploma. These are all things that some families I interview don't have any of. So I'm really, really careful and to be open with families that I meet. And so I meet everyone personally, sit down and talk to them when I ask them if they're interested in participating in the study. And so on several occasions, and I have to be ready for, I have to be cognizant and respectful of people's time. And the way in which I approach my research, and this is just the way I was trained, and the way I really, really think about what I'm doing, I value the time and knowledge that people are sharing with me and treat it as that. And so because I'm getting information and I'm asking questions of people who may not be socially, don't have a college degree, for example, or a master's or a public, PhD, I view that knowledge just as important, if not more important, than what I'm bringing to the table. And oftentimes, people want to, I ask personal questions, and if they want to know, I ask them, do you have any questions for me? And so oftentimes, we spend an hour talking. They want to ask questions about me, and so I'm very open about that as well. There was a second part to that question. I'm not sure I answered.
How do families perceive your interest in your experiences?
Well, I think I've been studying autism for a long time, and so and I've always been very interested in families and inequalities in health, and so I kind of start there. And I tell people, I've been studying autism for many years, and I tell them a little bit about my research before, and that I think families generally really want to just talk to somebody about what they're going through. I mean, I've never, and of course this is probably some level of selection bias. If someone didn't want to talk to me, they're just not going to talk to me. So the families that are talking to me, they really want to talk to me, and because they have a story. They can really, I tell them right away what I'm interested in learning from them in terms of the barriers and the successes that they've experienced along the way, and so I don't know how they perceive me. That's a really great question. My feeling is that initially maybe some participants are a little weary about what I'm doing, but then once we start talking and I start asking them questions, they're very open to talk to me. I wish I knew how people perceive me. I don't know. I can only go based on the interaction that we have together. Some families send me, I'll send information. We'll talk about, maybe we're talking about something specific in Georgia, and you might be interested in this resource or whatnot, and then other families send me information. So it kind of, for some families, it goes back and forth. And then I continually, because I'm doing an ethnography, I'm actually in the clinic every week. So it operates 3 days a month. I see families over and over again. So then I get to sit down and talk to them and ask them how they're doing, and they ask me, well, how's your study going? So there's that sort of interaction that I have as well. It's not like I showed up once and then I'm not there anymore, because when they come back in the clinic 3 months later, I'm usually still there.
Right.
That just gives you a little bit about
Moving
the process.
On to the next.
Yeah.
Moving on to the next question. One of the things is that financial resources from institutions, either insurers or providers, is one of the biggest barriers in providing enough access to services for families that really need it. Did you find something similar in talking to providers?
What was the last part of that question? Can you find something
similar? As in, one of the biggest barriers is providing enough access to services for families that really need it. So this is what is generally found in financial resources from institutions. So did you also find something similar when you talked to the providers?
Yes. So I think this is a real struggle, because especially for providers who have been working in the field for a long time and they realize the benefits of early intervention, and if a child is having severe behavioral problems and could benefit greatly, and the family could benefit greatly from an intensive 6-month behavioral modification or whatever it might be, or speech therapy, it's very frustrating because you're limited. I see that clinicians are limited within the resources that the families have. It could be geographic, right? Do they live close enough to the services that are available that Medicaid would cover or that their insurance would cover? It kind of goes back to the stories that I was talking about. So it is very frustrating for my impression through my observations and talking to the providers that are working here is that it is very frustrating, and they have to be creative about how they approach recommendations, because what if do you make a recommendation for a therapy that they that they can never achieve? And so I think it gets down to really an issue of justice, of social justice, in terms of how there is no safety net that will actually accommodate what families need in these particular situations. And it is very frustrating for clinicians from my observation. I don't know if that answers the question, but it's part of the reality of the situation that I'm experiencing. In my first research project, I followed some of the early parent advocates who really promoted putting autism on map. They were the ones who started the International Meeting for Autism Research, right? And all of this great attention to autism and research and the like, and services. And after 10 years of the International Meeting for Autism Research, one of the key parents was saying, we have thousands of people doing research now, but we don't really know what causes it. We don't really have a cure, and there's therapies, but it's only available for people who can afford it. So we really haven't gone that far, and so I think that's just really telling of the situation that we're in terms of thinking about this.
Yeah. So the next question is it not also the responsibility of the provider to accept Medicaid payments? For example, in Illinois specifically, Medicaid will cover ABA, but providers are unwilling to take the prolonged and reduced payment. So how might you suggest moving providers in the direction of accepting Medicaid payments?
So providers meaning like the ABA therapist? Is that in that question? Because apparently Georgia's the same. Apparently, if Medicaid is supposed to start now covering ABA, but the people who offer the ABA might not necessarily take Medicaid. Is that the question? And so I don't know. That's a really good. That's like a really good policy question to think about. What kind of mandates need to be placed on providers? Like, do they have to accept a certain number of Medicaid patients? And that's kind of beyond my knowledge in terms of understanding the nuances at the policy level. So if I'm a provider and I offer speech, OT, or ABA, how many, I don't know, if there is a mandate, or if even if there is a law that says, Medicaid is going to pay for this particular therapy, does it actually get implemented? And if so, how? And what are the stipulations and things like that? That's a really good question. And my guess is because Medicaid is operated on, every state can decide how they allocate these resources, that there's going to be a difference depending on what state you live in. And so in Illinois, it's probably very different than Georgia, for example. That would be a really great study to do. I'd recommend somebody to do something like that if it hasn't already, if we haven't already looked at Medicaid data, which some folks have. But in terms of how it's regulated, or how do we make sure that it's available? Because my experience just working in the clinic is that parents have a hard time getting these basic services through Medicaid.
Right. I'd start asking the research questions next. This is a question about your research. Did your participants express a strong identification with the autism label? Did they identify with the discourse of autism moms elsewhere in the US? Or did they focus more on the symptom than the syndrome? What do you think their identification was impacted by the many earlier non-autism diagnoses you noted that their children received?
So are they, in terms of the participants who I interviewed, do they identify with the autism diagnosis, or really just more the symptoms? Is that sort of the question?
Yes.
Okay. Yeah. I would have to say that it's the symptoms, because the families that are coming to the clinic have been referred by, you have to have a referral from a physician, a primary care physician, or usually, or maybe it comes from, when they start school and then they go to the physician and then they get referred. The pathways are all different. I don't know that there is a similar pathway. And that's something I still need to investigate, or really analyze, because I ask parents, tell me about the pathway, and there's no straight line. It's really many different curves, and backwards and forwards and those kinds of things, various different professionals that they see. But my guess is that for some parents it's the symptoms, because that's what's driving, they come to the clinic not realizing or knowing really what autism is. So it's not like they have this idea of what it might be lumped into this diagnosis, because if it's speech delay, or if it's really aggressive behavior, I think it's the symptoms that are driving parents to go. They need help in this area, and then the diagnosis comes with it, right? But then there's other parents, and this is related to the earlier question. Does the diagnosis have value? Some parents are coming in there just to get that diagnosis, and so they identify with it completely as the way forward. And it's not necessarily a question, I think, was part of our conversation, because we were really just talking about the process of and the barriers that they were experiencing getting to the clinic, and then getting the services. I think the services are tailored to really address the particular symptoms that their child is experiencing, because as you know, every child is different, and the needs are very different for each child. But that's a really good question, and something that I need to think about in terms of how families are identifying with the diagnosis, and or the symptoms, or maybe something else altogether. I mean, several of the families I interviewed, autism was just one of many different diagnoses, and so unlike the families that I interviewed for my first study, who were part of this research study on autism, that first study, I would say that those families definitely had more identity around autism and the diagnosis. Where these families, it's different. Several of these families, and I don't know how many just off the top of my head, because I haven't analyzed all the data yet, have comorbidities. They could have things like cerebral palsy, for example, or there's other kinds of comorbidities that are part of their visit, where autism is just one other thing, and it's not necessarily wrapped up in a particular, this is the one thing that they're experiencing in terms of their understanding and identity of their child.
Right, thank you. Another question about your research is that do you offer incentives or compensation for the family for participating, like transport money, considering that some of them have low income? Or if they have not, how have they received this? And if yes, how have you worked this out?
Yeah. So that's a really good question. And I've always made it a practice of my research to be able to compensate families in some way, because I view their time as valuable and limited. I'm always surprised that people will talk to me, and when I learn about, the limits of their time, I'm so thankful. And so when I was writing, we were able to get research funds for this project. And so when I was taking it through the IRB, I think I had like a $40 gift card as part of my compensation. And the IRB folks came back and said, we don't think that's enough money because you need to consider that caring for a child with a disability is going to cost more money. And so I upped it to $60, and that's what I offered the families, was a $60 gift card. And that's just part of the informed consent, So when we start the interview, and when I tell them that if they're interested in participating, there is the compensation, and I would always meet them where was most convenient for them at whatever time or day was most convenient for them. Whether, like for example, the woman I interviewed, I went to her work during her lunch hour because I knew it was going to be really hard to meet her otherwise. I did conduct a lot of phone interviews because of the distance that families were traveling. It just was inconceivable for either one of us to drive, that far. And so I did conduct a lot of interviews on the telephone. And some families were like, would tell me, I don't want that. Give it to somebody else, or they would say that. But I was insistent. I'm like, no, take your kids out to lunch or whatever. Spend it on yourself or whatever. I don't care. But this is what we're doing. And so I try to make a practice of it. It's hard to do if there's limited research funding for qualitative research, but I think that's an important practice to do, to compensate your informants who are taking valuable time out of their lives to share with you.
Right. So with the parents you interviewed, did you discuss their impressions of the diagnostic process? If so, did these parents express any surprise of how a diagnosis of autism is made and what was done during the evaluation?
Mm-hmm. So some families come in that I interview have already had like a psych evaluation, like a psychological clinical diagnosis, where maybe it was an ADOS or one of the many tools that can be used for diagnosis. Other families, and I'm not quite sure, I want to say it's like maybe 60% of the sample actually got their diagnosis for the first time at the clinic, and that's just a clinical diagnosis. And so it's very different than a psych evaluation. And so I think the way in which this particular clinic operates is that it's very personal. There's criteria that the physician goes through and talks about with the families, and everybody's approach is different, and this is just the approach that I've experienced in this clinic. And so it's the families that, going through the list of criteria and the different kinds of ways in which autism can be expressed, families will either, say, yeah, that sounds about right, and then they'll follow up with an example. And then other times they're like, no, that doesn't seem to fit. But I didn't talk to any families who felt like it wasn't something that was legitimate. They all felt like that was indeed what was going on with their child. And perhaps it's the way in the process in which they experienced that particular clinical diagnosis, which is very different. There's so many ways in which, like I said, I feel like there could be a whole summer institute just on diagnosis and how these processes happen, whether it be, in a clinic like I'm observing in the psych evaluation, or even in the educational system, and how there's these just different processes and ways in which we're thinking about how people come to understand this.
What are your thoughts about how to incorporate the concept of intersectionality into research and work around social ecological models, particularly in autism research?
So, this is, I just came back from the American Sociology Association, and we were just talking about methodologies with intersectionality, and I realize that, and there's different models out there. I mean, the eco-social model definitely is within the same, domain of thinking about these different levels. But I think what's important to think about in terms of intersectionality, it's not only about the identities and the experiences that are shaped through different levels. I mean, it could be race, it could be class, it could be sexuality, it could be gender, it could be disability, it could be all, it could be so many different things, but there's some that are more salient than others, right, in terms of shaping someone's experience. But with intersectionality, I think the key difference is how those different intersections of identities come together, and people experience levels of discrimination, or levels they're embedded within different hierarchies of power. And so because we all like I mentioned earlier, I'm heterosexual, female, I have these different identities that shape who I am, but that particular, the person that I am, I don't experience the kind, I don't experience, maybe I do to a certain degree, experience some level of power differential from someone who's differently situated than me. It's not an easy answer, and in terms of thinking about this particular framework, because none of these identities, whether they be gender, class, race, are static, right? They're interacting with one another and constantly changing, and so it's turning out, for me at least, to be more difficult than I thought in thinking about how these types of identities interact with one another within the context of different structural, institutional, and individual levels of analysis. But I think, the eco-social model, I could certainly tie that in here too. It's another way of thinking about this in terms of the different levels. Absolutely. I hope that helps. Maybe brings up more questions than answers.
Right. So I think we'll take one last question.
Okay.
Medicaid-driven disparities seem to be largely reliant on governmental support and climate. However, are there any things we could do as a clinic or as a community to reduce the disparity?
Yes, that's a really good question. I think the first, it's great that there's communities that actually have clinics. So if those don't exist, maybe they need to exist, or we need to identify the needs of particular communities, right? And start small in terms of thinking about what can we do. Like, so in Atlanta or in Georgia, there's a large Latino population that has become part of our communities, and having bilingual providers, having or even just knowing who the bilingual providers are is one thing, right? Where are the bilingual speech therapists, occupational therapists? Where are those resources? And so just generating these kinds of networks is really important in terms of helping people identify who they need to contact. And those are always moving targets too, just because laws change, people move, policies change in particular hospitals and clinics and things like that. And so I think that's one place to start. Something that and so like in Atlanta, one of the things that another group is doing is just really developing a consortium of Latino practitioners and people who do research so that we are all in conversation with one another, including families, right? And so the inclusion of people who you are serving is also very important in terms of thinking about, what might some of those solutions be. So I've learned from families, because part of the survey that we're doing is a quality of care survey to try to assess, what's going well with the clinic and then where the families are getting stuck. And getting to the clinic isn't the problem. Getting the diagnosis, once they're there, that's not the problem. The problems are, in the educational system and, trying to navigate, services that don't exist, essentially. And so some parents are like, it would be really great if maybe there was a mobile unit that went to different neighborhoods that offered some level of speech or occupational therapy. And so families can actually go there. Maybe it's close to public transportation. So really thinking about what we learned from families in terms of where they're getting stuck and how we might have to alter the model in which we think might actually work. I think that's one of the benefits of talking to families is just learning from families what some of those solutions might actually look like. I mean, it's kind of a form of community-based participatory research where you're engaging with communities to really understand, why public transportation really matters, for example, and what that actually means for someone who has a child with a disability.
This is Christina again. I just want to thank you for answering all those questions. I think, again, what you mentioned a second ago, that some of the answers probably brought up more questions. And I think one of the benefits of having the Summer Institute is having these discussions and coming up with more questions and more discussions and everything. So I think in a good way you've left us all really considering all the information you presented and really what we're faced with as clinicians and researchers and stuff like that. Mm-hmm. So thank you for providing a really good presentation, but as well as adding in this additional information for us to think about. So we are actually out of time for today. So I'd like to just thank you, Dr. Jennifer Singh, for presenting today, just this wonderful presentation, answering all questions. Thank you to Soumya for facilitating the question and answer section. We got her packaged in from India, so it was awesome. And then thank you to everyone for joining us as well. We saw a lot of names in the session, and so I want to thank everybody for participating, asking questions and everything. There'll be video replays will be available on the INSAR website following the conclusion of the 6-session series. So after next week, which is our last session, all the videos will be put online on the INSAR website. You can log into your My INSAR account and access them there. If you just created a profile on the INSAR website to register for today's presentation, there are a lot of benefits of actually joining INSAR as a dues-paying member, so we encourage you to explore those benefits. You can become a member of INSAR by visiting the membership page of the website. If you have questions or want to get more involved, you can contact the Student Training Committee at studentcommittee@autism-insar.org. Again, that's studentcommittee@autism-insar.org. And we hope that you've enjoyed this session of the 2017 INSAR Summer Institute. Please take a few minutes to fill out the comment section at the end of your session, at the end of the survey at the end of the session. We'll also be sending out a survey at the end of the summer to be getting more feedback as well. Join us next week when Dr. Nidhi Singhal discusses translation of research and services across cultures, autism research in India. So thank you all again for listening and participating. Thank you, Jennifer and Soumya, and we hope to see you all again next week.
Great. Thank you. Bye-bye.
Thank you. Bye.